Good afternoon, everybody. My name is Ben Doherty. I'm a journalist on the Guardian newspaper, and I have the great pleasure, thanks to Pete Lewis, for being your host this afternoon for Shifting the Needle, Protecting Australia by Vaccinating Our Region. It needs no introduction what we're talking about here, the global pandemic that has seized this country and this world. I'm just turning notifications off on my computer so I can give you my undivided attention. But we woke up this morning to some interesting news and some developments. We have the UK now talking about starting vaccinations this week, and there's been a great deal of discussion in recent weeks and months about a queue forming for vaccines and which vaccine's going to be approved first and ready for rollout. We seem to be approaching a tipping point, on the verge of getting there. So it feels like a germane time to be sitting down and having this discussion about what Australia's role is in the region, in the Indo-Pacific, and throughout Southeast Asia, about the role that Australia can play in assisting the world in beginning to come to terms and conquering this pandemic. This idea that you can't be safe from this virus while you're surrounded by it, that no one's protected from this virus while there are still populations out in the world who are unprotected. I'm not going to talk very much today. We've got an extraordinary panel who I'll introduce right now. Just very quickly, for those of us who are in Australia, and I know we have people joining from overseas, I would like to pay my respects to Indigenous elders, past, present and emerging. I sit here this afternoon on Gadigal country. As well, a little bit of further housekeeping. I'm sitting at my home. You can see my sort of hipster chic unpainted brick wall behind me. Upstairs is my young son, and he may wake up soon. And if there's a bit of squawking coming down the line, that's coming from my house, and I apologise in advance for that. Some ground rules. I know a lot of people will have been through these before. We encourage people to have their cameras on so we can see people. Do use the chat function to ask questions. We will try to get to questions as much as possible. We're very keen to have this to be as a sort of Socratic a discussion as possible, and so feel very free to participate as much as possible. Our panel today is extraordinarily distinguished. Bill Bowtell needs no introduction, so I'm going to give him one, but a diplomat by training with postings all over the world and a senior advisor to former Australian health ministers, is very well known in this country and around the world for his role in combating the HIV/AIDS epidemic, and his significant role in introducing the Medicare health insurance system. Dr. Bobby John is joining us. He's the Managing Director of Equitas Consulting in India. Dr. Bobby John is in New Delhi, where he joins us from this morning. Thank you for getting up very early, Dr. John. Dr. John trained in Pune and has done a lot of work with the Indian Army, working in Maharashtra. We have Negaya Chorley, who is the Chief Executive of Results International Australia, who has 20 years experience in human rights, working in local, national and global levels, particularly working with communities across Africa, Asia and the Pacific Islands. And we also have, and I'm not sure if I've seen them online, but I'm sure they're here with us, Kate Reagh and April Wong from Minter Ellison's in Sydney. On behalf of Results International Australia, they've recently produced a report entitled The Right to Health, Lessons for COVID-19 from the History of HIV. So we'll talk with Kate and April in a little while. Can I begin by talking about one of the things that we've seen discussed recently, and obviously there's an extreme and justified focus on the impacts of COVID-19, the health impacts of COVID-19 are very much the kind of pointy end of dealing with this pandemic, but there are also the secondary impacts, the social, the economic, and the allied health impacts. And Negaya, I wanted to ask you to begin with. The Gates Foundation recently talked in their Goalkeepers report, suggesting in terms of the SDG goals, the world has lost 25 years in 25 weeks with this COVID-19. What are the secondary impacts we're seeing of COVID-19, and what are we going to see across the region?
Thank you so much, Ben. And just to firstly say, it's wonderful to be here with you all. It's a great audience and a fabulous panel, so thank you so much. So yeah, every year the Bill and Melinda Gates Foundation release a report called Goalkeepers. And what that report does is really track how we're going as a global community in really achieving the Sustainable Development Goals. So they look at a whole range of poverty-related indicators. And every year for 20 years, we've been making excellent progress across a whole range of areas. And for the first time in 20 years, that progress has been stopped in its tracks because, of course, of COVID-19. So the Spanish flu of 1918 was described as a set of mutually reinforcing catastrophes. And I think the same can very much be said of COVID-19. And these mutually reinforcing catastrophes are especially pronounced in developing countries. I'll give you 5 very simple, brief examples, starting with poverty. So as a result of the pandemic, an additional 37 million people have been pushed into extreme poverty. When we look here in our own region at Pacific Island nations, they are, of course, heavily dependent on tourism, heavily dependent on remittances, and of course, all of that stopped when this pandemic kicked in. The other area is vaccines. And when I say vaccines, I'm not talking about a COVID-19 vaccines, I'm talking about traditional childhood vaccines. They have been one of the most powerful tools in the history of public health. But again, once COVID-19 kicked in, it meant a lot of these vaccine programs needed to be put on hold. And what that means is we're seeing a rise in vaccine preventable illnesses such as pneumonia and diarrhea. And these two are the biggest causes of death of children under 5. On top of that, you know, the world had almost completely eradicated polio, but because of COVID-19, a lot of those polio vaccination campaigns have also been put on hold. And what that means is we might start to see polio come back in certain quarters of the world, which would be really disappointing. The other area, of course, that we can relate to in Australia is education. So at the moment, we've got 1.3 billion boys and girls out of school, but it's especially challenging for people in developing countries. They don't necessarily have access to remote learning or web-based learning. And we know from the history of Ebola that when boys and girls stopped attending school, a lot of the boys went back to school once the epidemic was controlled, but a lot of the girls never returned to school. And that's going to obviously have profound impacts on their future life trajectory. The other area is child maternal health. So when health systems are under stress, as they are in so many countries at the moment, we know that babies often die, and we're starting to see that around the world. We're seeing maternal mortality and child mortality going up. And just finally, and we've got experts who can speak to this, but global health, pandemics, of course, are not new to developing countries. So we know, of course, that so many developing countries are still very much under the grip of TB, HIV, and malaria. And every year, in fact, 1.5 million people die from TB, and we're just about to reach that point with COVID-19. So it's interesting to think about what's going on every day in developing countries. But having just said that, there has been progress in recent years on TB, HIV, and malaria. But again, because of COVID-19, we're starting to see a regression, which is really concerning. There was an interesting report published in The Lancet, which predicts we're going to see a rise in HIV of 10%, of TB of 20%, and of malaria of 36% over the next 5 years. So these are really worrying trends. Thanks, Ben.
Thanks, Negaya. That was a very comprehensive look at exactly the sort of challenges that are being faced in our region. Dr. Bobby John in New Delhi, I'm really interested in the Indian experience. India, is a very different country from Australia, just not only in terms of size, but in terms of disparate access to healthcare and the fragility or the robustness of public health systems. Can you talk to us about, I suppose, how this pandemic has unfolded across India and what have been some of those secondary impacts? I mean, one of the most striking things I think we saw at the beginning of the pandemic was this extraordinary migration of people, migrant labourers who've been drawn to Delhi and to Bombay and to other centres for work, walking literally hundreds of kilometres to try to get home. Because that was the only place they felt that was safe. Can you talk about the secondary impacts of this pandemic in India?
Ben, thank you, and thank you for having me here at Australia, and good morning to all of you. Where I'm sitting at, this city or urban conglomeration of New Delhi, National Capital Region, is about 25 million people. That's all of Australia, I think, give, take a little bit. India is a fifth of humanity. And in February, March, when news of the COVID outbreak began and just around the time that the pandemic word began being appended to it, the conversation shifted quickly to how do we try and staunch the numbers. And what we had was a rather stringent lockdown over 21 days and then extended to 45 and then continued on. And one of the comments that I made at that point in time was lockdowns are a very blunt tool. They're a tiger that you can easily mount, but it's harder to get off because it's the easiest solution to something that's emerging. The harder solution would have been and continues to be how to identify people with high quality, low cost, easily available testing, tracking out who their primary and secondary contacts are, and enabling then the provisioning of early treatment or isolation, all of which have been very patchy in a country that's, like I said, a fifth of humanity. It's a very large continental landmass. And what we are seeing right now, 9 months into the pandemic and the response here in India, is that we have urban agglomerations which are showing up larger numbers. Mumbai led it up first, partly also a reflection of the density of population and the numbers of people that are cramped into that city, especially in the peri-urban sprawls. Next up was Delhi, which is at this point in time as we speak, seeing through one of its worst spikes that we have seen in the country. And I suspect we will continue to see this going on. The metaphor that I want to leave with you is this, and we can continue into the conversation later on with the secondary effects and things like that is, think about it as a massive forest or bush, which is dry, which is susceptible to forest fires. You're not strangers to bushfires and forest fires. Once started, either you put it all out, and that's a massive task by itself, or you figure out ways of segmenting it and begin predicting where is it going to kind of spread next. And that will be a function of the dryness of the underbrush, the wind patterns, and where's the precipitation and where the natural boundaries are. The way our city and our population distributions are probably help us understand where the next spikes will be like and where we need to actually put our defenses up. Ben, the way you mentioned about large numbers of people moving, that's been one of the most difficult parts of a health emergency, where people have had to leave their homes simply because everything was shut down. Food was at a premium. People found it better or thought it better to go back home, where at least in the villages and homes, there would be a little bit more food on the farms. That's exacerbated an already strained infrastructure in the villages where people had left for job reasons, for economic reasons. The economic numbers are steadily telling us that we have a worsening crisis, both at the incomes level and also in terms of the prioritization of expenditures. Many kids are now out of school, and we know that that gap is going to widen. No amount of internet-based school delivery programs will ever match up the requirement of in-school training, partly because even though we have one of the largest internet penetrations and mobile phone populations in the world, it still does not mean that children have access to those devices or to those services. And so therefore that gap is going to increase. And everything else that Negaya has kind of pointed out to the health impacts, we are already beginning to see. And just to kind of again frame it back, we are talking about roughly 20% of the world, which is going to kind of go through this entire cycle.
A fifth of humanity, it's just quite extraordinary, those numbers, isn't it? Can I ask Dr. John, I mean, do you see the pandemic and its impacts being sort of disproportionately visited upon India's poor and India's rural populations? Are they suffering much more than say middle-class Indians in the big cities?
Not yet, and I think there is still the opportunity. If I were to kind of look at how the administrative divisions are, and I kind of think about 750 districts, not the states of the country, but the districts, the sub-state units, I think it's still, we are at about 250, 200 districts that are at this point in time, the front line of this fire, so to say, and there's the opportunity of doing things preventatively or mitigating it in about 500 of those. And how we go about doing that will shape up the final report card for what India is going to look like on the other side of this COVID pandemic.
Bill Bowtell, I was hoping I could come to you. Pandemics are not new. The history of the world has been shaped by epidemics and pandemics. You played a central role in leading Australia's response to HIV and indeed the world's response to that pandemic. Looking at COVID-19, we're almost approaching essentially a year since this pandemic was sort of known about publicly. What has the world done well, and what has the world done poorly, and what does the world need to do now to avoid some of these potential secondary impacts?
A few simple questions.
Yeah, three very big questions.
Yeah, good. Look, thanks to you, Ben, and Results and everybody for inviting me to have me along today. Right at the heart of it, I mean, I like to say nature creates viruses, but it's politicians who create pandemics. It was the big thing I learned from the HIV days. I was very young, and when I was the advisor to the health minister, and I didn't know very much about these things, I've got to say, at the time. And I did then tend to think that the progress of these things was inevitable and somehow dictated by the inherent qualities of the virus. But very quickly became obvious in the 80s that viruses come from nature all the time. Some are worse than others, some are more infectious, some have different properties. But it's basically the decisions taken by the politicians of the day, or not taken, that decide whether these perfectly manageable, basically, phenomena are allowed to get out. And as Bobby said, become like a fire that then sweeps all before it. And the countries that really understood that you could move swiftly and effectively at the beginnings of these things in that period when transmission was low, and once you knew what was going on, if you intervened effectively enough, you could stop the virus or contain it, and then over time do what Bobby would do, which is to get the firefighters into the embers and to damp it down. That was the lesson of the HIV period, that prevention works. We're very good at, in this thing, in the world we have it, the way we set up our international health systems on care and treatment, and then research into what happened. But before that, we should do a lot more in relation to prevention. Prevention of the circumstances that allow these things to happen in the first place, whether it's markets or animal husbandry or interaction between humans and viruses and so on. And then the preventive, the very rapid response when the virus is first detected. And, you know, between HIV and where we are with COVID, we did have decades where I thought that the world had learnt these lessons. We saw how really remarkably effectively, say, Ebola in West Africa was contained several times. And that's a really nasty disease. But thanks to the application of science and working quickly, and very importantly, the mobilization of the communities who were most affected by it, and that's another lesson of HIV I don't think it's being learnt in COVID, you know, the voice of the people with COVID or who are at risk of it, or the doctors and treaters and carers who are right there with them, being in part of the policy. But, you know, the prevention side of this has to be looked at. According to that Gates report, the amount of stimulus spent in the world is the almost inconceivably vast figure of $18 trillion this year alone. Well, the entire American economy is 20 trillion. So you imagine that amount of money. And if 1% of that had been spent on creating a more robust world health system, more robust way of detecting and containing and clobbering viruses before they got out of control, we would not be in the situation we are today, much less the expenditures that are now going to come next year with my goodness, you know, the rolling out of vaccines and the distribution and all of the things that will go on with that. So, and I wish I had more answers to it, but I do think if there's one lesson we got from HIV, it's the need to prevent before the problems become these vastly shocking disasters that we've seen in the last 25, 26 weeks.
You mentioned, Bill, that these viruses come from nature, but the response to them comes from people and from political leaders. Julie's just mentioned on the chat though that prevention in healthcare has never been very sexy. How do you sell prevention to the politicians and the people making these decisions? How do you get them in front of this to say this is what we need to do?
And with the greatest respect to my many friends who are doctors and clinicians, all of the spending is after the event. That's how we've structured the World Health System. We don't do much before, but we wait till the problem happens, till somebody breaks a leg or is in a car crash, and then we apply tremendous resources to fixing them up, and then we give a lot of grants to researchers to figure out how terrible car crashes are and so on. But you know, in Australia, for example, I think our health budget is about 140 billion. Drop in the ocean really, but 140 billion in federal and states. 98% of that budget goes on care and treatment. Less than 2% goes on public health. And Bobby may not know this, but the great difference within Australia in the last months has been between New South Wales and Victoria. After the HIV times, and as a result of that, the New South Wales governments over 20 and 30 years in their public health, they really paid a lot of attention and put a lot of money into strengthening that public health structure and making it very senior. That was abandoned pretty much in Victoria. So that when the big test came, New South Wales had a robust public health preventive structure, if you like, that came out of the HIV days, and Victoria did not, and it had to scramble to catch up when things started to go wrong. So, you know, the amount of investment you make, if you want prevention, you've got to pay for it. And pretty broadly in Australia and around the world, we don't. And then we're shocked when we don't prevent a little problem becoming a big one.
Well, let's talk about Australia's role then. As Australia cast itself as a sort of global middle power, and certainly a significant power in the Asia Pacific and in the Pacific, a fairly critical role. What should Australia's role in our region's emergence from this virus be? Negaya, I thought I'd come to you. The Morrison government's made some significant commitments through COVAX and bilaterally towards vaccines for our region. What is Australia proposing to do here?
Well, I'll mute myself first. So just to say, I mean, originally we had a lot of great statements coming from Scott Morrison and other leaders around the world. Scott Morrison said at the General Assembly in September that it's a moral responsibility for us to really vaccinate all of humanity. And of course, at the G20, there was a commitment to recognising the role of extensive immunisation as a global public good. So these were grand and lofty statements, but what's interesting in the Australian context is the Australian government, to their credit, have actually really backed up these statements with a set of really strong commitments, which I'll move to in a moment. But just to say, we in the sector, in the international aid and development sector, have been running a campaign. MICA have been key leaders, as have ACFID, and Results has also been a part. It was called End COVID for All. And really what we were saying to the government, actually building from what Bill was just saying, is that now is a moment to invest, particularly in our region, because otherwise the impacts moving forward are going to be significant. So we were calling for $2 billion, which sounds like a lot of money, but actually it's less than 1% of our domestic COVID spend. And we felt that now was a really important time to invest. So the government have delivered. They've actually committed 1.3 billion, which is a significant commitment. And part of that 500 million is for the rollout of a vaccine, particularly in the Pacific region. So there's a very strong commitment to working with Pacific Island nations to extensively roll out a vaccine. So I really see this, Ben, as a kind of reset. As I think many of our audience may be aware, we've seen consecutive cuts to our overseas aid budget over many years now. I think ANU estimates it's about 27% in real terms of our ODA, which no doubt had a profound impact on our partners throughout the world. And I think what this kind of new commitment of 1.3, it's a reset. It's, I think, us saying that our future is very much bound with the future of our region. We have a really strong leadership role to play here. And to its credit, the government has stood up and delivered. Thank you, Ben.
Dr. John, I'm interested what a COVID-19 vaccine rollout looks like in India. We have the UK seems to be first off the mark, saying they're going to start mass vaccinations. You mentioned before, India represents a fifth of humanity. How do you vaccinate a country of that size? I know there are sort of very well established polio vaccination programs. Do you sort of work on the back of those logistical, or that infrastructure, or do you need to sort of build something up from the ground for something of this size?
India may be a fifth of humanity, but 2 out of every 3 children born on the planet get an Indian vaccine, an India-made vaccine. And that's disproportionate to any production capacity in anywhere in the world. And that's something that's a tremendous advantage that India possesses at this point in time. We have the capability to manufacture at scale. And at this point in time, the Astra vaccine is definitely being manufactured in India, pending the final approvals. That will be one of the first ones that should be available, not only for India, but at quantities for the rest of the world. It's the current capacity is already spoken for by most of the developed world as we speak, but there's significant more capacity in the pipeline. And that's not just one manufacturer, but several of these at global scale. So production is not an issue. The costing should not be an issue because the production is going to be affordable. It's in a setting that is priced way lesser than perhaps in the northern world. And so therefore, costing should also not be an issue. What will be an issue is then figuring out the logistics of rolling out something that's not got the same emotional attachment as a childhood vaccine. Remember, a childhood vaccine, a baby being vaccinated has the most powerfully motivated person behind that baby, who is the mother. The mother's invested, and so she will stand in line or will wait for the immunization to be delivered to her child, or she'll scream for it. In this case, it's different. It's going to be adults. And the emotional investment into getting something, which frankly, we haven't really built the vaccine confidence around. That's not just for India, but globally. And politicians really haven't helped in that building up of a vaccine confidence story for COVID vaccines is something that we'll have to negotiate. And that's going to be tricky. Even with polio that you refer to, Ben, it was difficult in the last few stages where we were getting to literally the last few households, the resistance to taking a polio vaccine because they had misconceptions around the intent and the efficacy of, or the effectiveness or the harm that a potential vaccine could cause. This is of an entirely different order of magnitude, and that needs to be addressed, which is going to be both layered on top of the logistical nightmare. The last thing that I would want to add is this. Unlike polio, unlike any other vaccine, this is a scenario where we'll have multiplicity of vaccines play out in the same population. So if you got one vaccine on day 0, on day 28, how sure will you be that you will be getting the same vaccine that you got the previous time? You need to the same twice over. And that's going to be a logistical challenge, not just for India, but for the world. How do you track out? Do we label them differently? Will we expect people to remember, or do we have health systems that remember who got what, and how do we track people out? It's going to be another logistical nightmare.
Of course. Bill, I'm wondering if you could turn your mind towards the Pacific. These are sort of remote nations in lots of ways. They have often quite fragile public health systems. How do you design a vaccination program for the Pacific? Australia is going to be key to be able to get vaccines to these Pacific nations. How does that system need to be developed?
Yeah, just before I say that point that Bobby made about the link between childhood and mothers and vaccination, I hadn't thought of it. That's an excellent point. It really is. It's a key point, I think. And if you think about the Pacific or anywhere else, I'm sure those considerations must apply there. And when we think about the Pacific Islands, of course, there are many islands that don't have the problem at all. So it's not as if they're seeing illness there, and it's not related to children. So the way in which the vaccination programs would roll out and be acceptable to the people of those islands and be welcomed by them is obviously something that's got to be thought through really, really clearly. And what Bobby had to say was really important. Look, I think together with New Zealand, which is very important in this, Australia and New Zealand do have a very big role to play in the Pacific. The logistical questions are extremely important. The 6th of the world's land surface, is the Southwest Pacific, is a huge area, and getting it out, getting these vaccines out and then administering them is going to be a very big logistical and IT question, it seems to me. And I think that's where Australia and New Zealand can make a big deal of difference, just getting the systems right. I assume that with some vaccines, from what I understand, and Bobby might say, that there's a gap between the first and the second shot, and I don't know how long that would be. I'd be interested if somebody could explain that. So just getting people to come back the second time is a big deal. We know that from all vaccinations. One is good, but having people come back the second time, if that's important as it must be, then that's also going to be a tremendously challenging thing to do. Of course, the greatest vaccine of all is money. And I think there's one thing we're not short of in the world at the moment is money to do this, but it is organising principles, and the principles of equity and fairness and prioritisation and, let's be clear, rationing that's going to have to take place in the throughout 2021. There'll never be enough to meet the demand or the requirements on day one.
Yeah. One of the questions we've, and I feel very free to any of the panels to chip in here. Zach has asked in the chat around, on top of the complications of delivering the vaccines to populations all over the world, the growing influence of sort of misinformation campaigns around anti-vaccination campaigns. I mean, in the Pacific example, Samoa has very low rates of vaccination and had a terrible measles outbreak that resulted in the deaths of a lot of children. How do you sort of counter that information? How do you, I suppose, bring your public on board with the importance of the vaccination? And as you mentioned there, Bill, not just coming along once to get a vaccine, but being committed enough to come back a second time to make sure it works.
Clear, clean information delivered by people whose voice matters. And this is absolutely critical. And the understanding that politicians and public leaders who've got voice clearly recognizing that their role is supportive to good science. They cannot preempt science. They cannot come ahead of science. They have to be lockstep, but just behind the science part of it. Because if there is even the slightest hint that our rush towards getting a vaccine is politically motivated rather than being scientifically led, will cause ripple effects in populations and cause people to have hesitancy and give rise to a field day to those that would take correlation as causation. Look, people will die, not of COVID, but of the regular stuff that people die from. COVID just happens to be an overlaying context right now. And so therefore, when a vaccination program is going on and somebody dies of a Hodgkin's lymphoma for which they were being treated, and that gets misrepresented as a COVID vaccine related death, and then somebody, just as earlier this morning, I was just watching somebody very respected respond to a list that he had put out, and he had just put out that there would be 64 multiple sclerosis deaths, right? And suddenly this whole world has said, will this vaccine cause an MS thing? And that's all it takes, one misplaced word, and the whole fire starts off again. And then we have a very susceptible population that would be exquisitely sensitive to what political messaging will be looking like. And so this is where one would ask, one would implore, one would really demand that politicians and people with public voices walk just a shade behind the science part of it.
I agree entirely. One of the lessons with HIV, when we had to get out and moderate behaviour change or distribute condoms or clean needles, was peer-to-peer education. Politicians are not the people to do this at all. If you want to convince a sex worker about the need to have condoms, please send and fund in many sex workers to make that case. Or an injecting drug user, or from a particular religious group, faith group, or gay men. The people who are most credible are people who look like the people you want to convince. They're telling science and they're telling the truth. What is, as I think we all know, misinformation is one thing when it's outside governments, and I think next year we have to cope with, regrettably, some governments who are in the business of misinformation as well. And this is, I think, can only be countered by a mobilisation of the people, if you like, and people of goodwill, and must fund that broad community-based response, just exactly for the reasons that Bobby said. People are going to get vaccinated in their millions, and a percentage of those sometime later are going to die from something.
Yeah.
And you've got to stop the idea that there's, the cause and effect. It's very important.
Understood. I'd like to introduce. Sorry, I just did it. I knew I was not going to get through an hour on Zoom without talking while I was muted. I apologise, everybody. Can I introduce now Kate and April from Minter Ellison? I hope you're out there. I haven't yet seen you, but Kate and April have written The Right to Health: Lessons from COVID-19 from the History of HIV. And one of the ideas that they've discussed in this, and one of the emerging fields of international law, is this idea around a right to health. I'm wondering, Kate and April, if you can tell us about the right to health and exactly what that means in legal terms. What might the impacts of and what might a right to health look like in relation to COVID-19 and accessing a vaccine?
Thanks, Ben, for that introduction. So as you mentioned, we wrote a report about how governments in developing countries have responded to previous health crises and the interaction between this notion of the right to health and the protection of IP rights. And it illustrates that how a lot of governments in the past have taken rather productive pathways to advocate for and facilitate equal access to antiretroviral therapy, which is HIV treatment. So we're drawing upon that example and seeing whether or not community groups and advocate groups can also follow those lessons that we've learned from HIV in advocating for access for a COVID-19 treatment. And the case studies that we examined and the countries that we looked at were India, Indonesia, Kenya, Papua New Guinea, and South Africa. My colleague Kate now will talk about what the right to health means in legal terms.
Thanks, April. So the right to health is the idea that everyone has the right to enjoy the highest attainable level of health. It's a fundamental human right that's actually interconnected and tied with other human rights, such as the right to food, education, and work. A rights approach to health provides clear principles for setting and evaluating health policy, access, service, and delivery of health medication and treatments. The core standards of a rights-based approach are summed up in what has become known as the panel principles, which is adopted by the United Nations. And one of the principles is legality, which means that right to health should form part of domestic law. Several international treaties have also codified right to health, which includes Universal Declaration of Human Rights and the International Covenant on Social, Economic, and Cultural Rights. Some of our case study countries are also signatory to these treaties, meaning that right to health should theoretically be recognized and observed at a domestic level. However, we have observed in our research that oftentimes it's actually difficult to legally enforce international law obligations, and we have seen in several of our case study countries. So in other words, the principle of right to health is really only as good as the people in power enforcing it, so the government, judiciary, and policymakers. So the general impacts of right to health can be recognized, should be recognized at a national level. So our research shows that at a minimum, all countries should implement national medicines programs and mandate in domestic law that COVID treatments should be accessible to all. Our research shows that this can be achieved. This can be achieved as several countries, such as India, Kenya, and South Africa, have continued to lower their HIV infection rates over time by prioritizing citizens' legal rights to receive medications within their legal framework.
So, for example, in India, there's a specific legislation which mandates access to antiretroviral therapy for people living with HIV. And, it creates the stigma and discrimination against these people living with HIV as a punishable offense. And it's really amazing because although India was one of the top countries that had the highest HIV rates, it's also one of the countries that have significantly lowered its HIV prevalence rates in recent years to date. And, them being able to codify the right to health in its domestic legislation has been hailed as a great example of how COVID-19 treatment should also be perhaps mandated in a way in these developing countries' legislation. So despite that, we've also seen that the law can really only go so far to alleviate health crises. For example, advocate groups in India were the ones who were actually at the forefront of opposing patent applications for HIV medications in 2006. And advocate groups in India were the ones who actually successfully campaigned for free second-line antiretroviral medication and dispensing free medication and diagnostic services to rural communities. And in Indonesia, advocate groups have been fundamental to alleviate the stigma and discrimination against people living with HIV. The Indonesia AIDS Coalition campaigned to lower the price of this medication by as much as 48%, resulting in approximately 50,000 more people receiving such medication. And the UN AIDS has also come up with an app called Ask Marlo, where people living with HIV are able to link up with a health counselor or even book an HIV test. And these digital platforms are very important, especially we've talked about the danger of misinformation previously in this panel, to ensure that people are having equal access to the correct information and that such information is being informed by public health guidance and the World Health Organization. So we consider that these steps taken by advocate groups in Indonesia will really lay the groundwork for what's to come when COVID-19 treatment becomes available and a vaccine gets distributed. Because we've already seen reports of stigma and social isolation against people who have contracted COVID-19, particularly in Indonesia. And it's really important that these communities normalize the virus and, more importantly, normalize and accept the importance of a vaccine in this time.
So building on that history and drawing from those lessons, thanks very much, April. Cooperation between government and health organizations is really paramount in prioritizing approaches to beat this pandemic. We can see this trend between high rates of COVID testing and low rates of infection and death in countries like Japan and South Korea, Thailand and Taiwan. And one thing these countries all have in common is governments are willing to cooperate, and most importantly, they follow the health guidance of global public health organizations such as the World Health Organization. A unified approach between government and the World Health Organization is crucial to beat misinformation about COVID. So building on this history and drawing from lessons of advocates that April has mentioned regarding atrial therapy, individual countries regionally and globally and international organizations have a central role during the COVID pandemic and ensuring that life-saving treatments are affordable and accessible. In April 2020, the World Health Organization and other leading global health and financing bodies partnered to create the Access to COVID Tools Accelerator, we'll call it ACT Accelerator, to accelerate the development and promote timely and equitable access to COVID treatments globally. As various COVID treatments are being tested, a clear and concise plan on how a vaccine will be distributed globally has not yet been set out. The ACT Accelerator requires significant more funding in order to achieve these ambitious goals, and a total of $31.3 billion over 12 months to June 2021. That being said, the way in which previous health crises such as HIV have been dealt with have paved a better way for access to COVID treatments.
Look, thank you very much to you, Kate and April. I think it's been put in the chat, but we will make sure it goes in there again. There's a lot to draw down on that around the right to health and what it could mean, and in a COVID context and more broadly. So thank you very much for your work on that. We'll make sure that everybody can access that report. I was wondering if I could come back to you, Bill. One of the things that Kate and April mentioned there was around looking at high-risk groups and groups facing discrimination and stigma. One of the things that was characteristic of the HIV response, I suppose, was a growing understanding of that discrimination that was faced by high-risk groups. And I'm wondering, did a successful pandemic response in that case also shift social values? And I suppose the question is, which came first? Was a shift in social values the result of a successful pandemic response, or was it a requirement of that response?
That's a very good question again. The one thing, a very funny binary in Australia and around the world came at the beginning of HIV, where it was falsely put by a lot of people that the choice we had to make was between tough action, strong action, to quarantine and isolate and sanction those terrible people with HIV, or look after their human rights. You couldn't have both, right? You couldn't look after the rights of the individual and the well-being of the general community. It was a false binary. It was badly politically misused, because we started to find that if you looked after the human rights of the people most at risk of the disease or who had it, and you strengthened the anti-discrimination laws and you made the discrimination illegal and called it out wherever you could, it was much better. You brought people into treatment. You didn't punish or ostracize them for their temerity in acquiring a virus and becoming sick, as we've seen. And we've seen that recently, even in Australia, with the weight of the police and all of this stuff used against people who've got the virus. It's silly. It's not an either or, it's an and. So the more, as Kate and April was saying, you strengthen human rights, that you bring people into the treatment regime, that you treat them regardless of any other consideration, the better off the whole of the society will be. So I think it was a very important point to come out of HIV. And Bobby would remember, I was always struck with Ebola. Remember when Ebola came in West Africa 10 years ago, and the first instance was people in moon suits, and they came down and they separated people, and the thing was a disaster. Then finally somebody had the very bright idea of working with the community who was most affected by Ebola, giving them the information, bringing them together, and they collectively got on top of it really well. And I'm sure that's the right way to approach COVID-19, that we use the scientific information, we mobilise the people, we tell them the truth where we know what it is, certainly work through the doctors, who are very important. I saw one of the comments in the chat. You know, the doctors have to be educated about this too, because it's all new, and just work at that level. And I think that strengthens it, and make sure that we don't have this false binary come that somehow being tough on COVID means to incarcerate or stigmatise or repel people. That would be a disaster when it comes to the obvious fact that we need to bring them in to be vaccinated once and then twice, and so on.
Dr. John, do you have any comments about how you sort of counter that discrimination or that stigma that's a potential repercussion of something like COVID-19?
public health has got two words, the public and health. And they are different from the way we make our initial responses, which is it's a law and order situation. There's an epidemic going on, people need to stay behind doors, send the police. Any defaulter becomes a problem for general society and is treated as problematic in a law and order sense. And that doesn't help. That's a lesson. I mean, I was listening to Kate and April's report, and I've read that. While we have enshrined right to health in many of our jurisdictions, they have come because we have seen the deleterious effects of using policing as a public health measure. You cannot have criminalized sex work and expect for better HIV control. That's one of the significant lessons that we've learned. We cannot have drug abuse being criminalized and put people behind bars and expect that there will be better reporting or better substitution therapies. So also for the COVID context, you cannot criminalize or stigmatize people. You cannot use law and order mechanisms to address what is a public problem and a health issue. And so therefore, how do we get the sensitivity into approaching people? Is it going to be people like you and I who are going to be talking to you and I? Is it going to be the concern about my well-being that prompts the conversation around what do we do together so that you are safe and I am safe? And that's the conversation that needs to happen. And somewhere along the line, we have to let go of the notions that it requires a strong arm. It requires a strong, empathetic conversation in the public spaces, in the family rooms, and between professionals. Even professionals, medical professionals, are guilty of accentuating the problem of stigmatization and of calling for stringent measures devoid of empathy. And that's where, I mean, I understand that. You can't be facing an ICU with an overload of patients that you can't take care of. But the answer is not saying, shut people down behind doors. It has to be more sensitive than that. And figuring that out is the larger political conversation that needs to be had. And I'm afraid that's not being had in the magnitude and the sensitivity that it deserves right now.
Negaya, I wanted to come back to you around Australia and its role in the region. We had a question a little earlier on from Hakiran Narula, a perspicacious and erudite young man, who has asked us, what's the opportunity for COVID-19 to help reshape the way Australians understand our development and engagement with countries like India and with the Asia-Pacific region? Can COVID be a bridge for evolving our views and moving from a regional self-interest to solidarity?
Look, that's an excellent question, Ben. It's interesting to think about the kind of broader history of Australia. So if we think right back to the end of the Second World War, which was, of course, a moment of great crisis, Australia really stood up. We were centrally involved in establishing the UN. We played a really key role in helping develop the international rules-based order. And of course, as we know from what Bill's been talking about, Australia was an incredible leader particularly in the early days of HIV. So I was working in London at the time with women all around the world living with HIV. And again, no matter where I was based in the world, Australia would be referred to as a leader. We also, of course, following the Asian tsunami, we stood up. The Australian government invested heavily. The Australian people gave generously. And I really think this new commitment of 1.3 billion, it's important, and I keep mentioning it because it's a real, I think it's the Australian government standing up and appreciating that we need to be a key player in the region, that we have a really strong role to play moving forward. So I guess the great challenge for us, and this goes back to the question, Ben, is how do all of us who care deeply about human rights, who care deeply about ending global poverty, how do we really maintain this momentum moving forward? Just to finally say, Ben, Results has worked with amazing partners, including Bobby, for some 30 years. We've worked with partners all over the world. And I guess from that extensive 30-year history, we know that when it comes to how we invest our funds, that there are three things in particular that have significant impact. And this really touches on and follows on from what both Bobby and Bill have been saying. I think COVID-19 has really taught us that we have to invest in public health, and as Bill said, in preventative medicine. So good public health is good economics. And of course, as we've seen through the pandemic, the inverse is also true. We need to ensure that health systems deliver for the most vulnerable. And of course, we need to also ensure that any rollout of a COVID strategy in the region complements the systems and the programs that are already in place to address HIV, TB and malaria. So we can't act in silos. We also, of course, know that education has a huge impact, and we've touched on the fact that at 1.3 billion boys and girls are not in education at the moment. So I think this is a real opportunity for Australia when we think about how to best invest the 1.3 billion, to think about the role of education. Education, of course, builds pathways for children into employment, into prosperity, and we also know it builds peaceful societies. And last, but certainly not least, of course, particularly when we think about the disproportionate impacts of the pandemic, we need to prioritise women and girls. As Melinda Gates says over and over again, this is not a side issue. If we are serious about tackling climate change, which of course is a key issue for the Pacific, if we want to promote economic prosperity, if we want to help build more peaceful societies, women and girls need to be right there at the centre. So I do see this as a really, I think, a new point in history in our relationship with the region. The Australian government have stood up, they are leading, they are contributing, and I think it's going to have ripple effects. Thank you, Ben.
Everybody, look, ladies and gentlemen, we've had an extraordinary conversation this afternoon. We've certainly sort of covered the waterfront from New Delhi to the South Pacific. So I think we've done pretty well for an hour on a Thursday afternoon. Can I thank you all very much for joining me, and can I ask you as well to thank our panelists who've been extraordinary to listen to this afternoon. Bill Bowtell, Dr. Bobby John in New Delhi, again, thank you for getting up early. Negaya Chorley and Kate Reagh and April Wong. Thank you all very much for your time, your comments and correspondence this afternoon. And again, thank you very much.
Thank you, Ben.
Thank you.